So hello guys and welcome to Global Perfusion Community. So today we have Mrs. Zahra. Sorry. So she is back with us with another topic that is related to cardioplegia, and her topic is types of cardioplegia and classification of cardioplegia which we use during pulmonary bypass. So we'll not waste our time and we'll soon dive into this topic. And now I welcome Miss Zahra, and she can present her topic.
Okay, thank you, Mr. Abu. Hello, everyone, and welcome to this web. It is truly a big honor for me to be here and talk about this topic, the type of cardioplegia solution. Before I start my presentation, I think it's very good to introduce myself. My name is Zahra Qambari. I'm a MSc student, actually master student in cardiovascular perfusion. So, please go to next slide. No, another slide, please. This is a presentation path that we talked about in last session that we want to talk about the second session type of cardioplegia solution in this session completely. So go to next slide. Thank you. And this slide is an abstract of this session. We provide a comprehensive overview of cardioplegia solution covering type, delivery system, and delivery strategies, actually temperature, pressure, and common pitfall. So go to next slide, please. Yes. This table shows classification of cardioplegia solution. Classification of cardioplegia based on component, actually based on composition. One type of them is crystalloid. Crystalloid cardioplegia made of electrolytes, buffer, and metabolic substrate without blood. The advantages of this type of cardioplegia is they are simple and inexpensive, and clear solutions allows good visualization of the surgical field. Other advantages of them is easy to prepare and standardize. And the disadvantages of this type of solution is no oxygen carrying capacity, less effective in long ischemic period. And if I want to say example of this type, such as St. Thomas, Casadale, or HDK, and Brett Schneider, actually all of them are crystalloid solution. Another type is blood solution. Blood cardioplegia, a mixture of patient oxygenated blood and crystalloid solution, usually in 4:1 ratio, actually, or 8:1. Advantages of blood cardioplegia is provide oxygen and metabolic support during arrest, better buffering capacity and osmotic balance, reduce myocardial edema and ischemic injury. And the disadvantages of this type of blood is a more complex preparation and delivery system, actually, and risk of hemodilution and microembolism. And the example of this type is back break, and the other one is microplegia. Microplegia is a type of cardioplegia with very concentrated cardioplegic drugs in a small volume of blood. And another one is mixed or hybrid cardioplegia, combines the properties of both crystalloid and blood solution for optimal myocardial protection. The example of this type is Del-Nido and HTK blood hybrid. If I want to talk about a little about HTK blood hybrid, this is a modified form of HTK solution in which a portion of the cardioplegia is mixed with oxygenated blood ratio like 4:1 or 8:1. The disadvantages of this type of solution is HTK blood hybrid is more complex preparation and not yet standardized in all centers. Some countries like Japan, Germany, and the United States use HTK blood hybrid for high-risk patients, example, left ventricle dysfunction, lung cross-clamp, time, and repeat or complex valve or coronary surgery. Go to next slide, please. Thank you. This slide discusses about the key components of cardioplegia solution. Some solution like crystallite, for example, ST Thomas, contain sodium, potassium, magnesium, calcium, buffers. HTK contains H-histidine. Histidine acts as buffer. T-tryptophan. Tryptophan reduce ischemic injury, and K related to ketoglycerate, actually energy substrate. Delnido contains potassium, magnesium, lidocaine, mannitol, bicarbonate, and blood, and low calcium actually. And if I talk more about each component, about potassium, I talk about and we discuss about last section completely. All of us know potassium lead to diastolic arrest by reduce the level of potassium outside the cell and reduce the difference between ionic level across membrane. About magnesium prevent coronary spasm, and when we consider that many patients face to, for example, calcium overload, we added magnesium in our cardioplegia solution. Bicarbonate, all of us know, act as actually buffer and help to maintain physiologic pH. Glucose provide energy substrate. Mannitol is a osmotic diuretic and reduce the fluid around the heart, and by reducing this, prevent edema. Antioxidant reduce the free radical injury. So go to next slide, please. Yes, let's zoom it. Thank you. Key practical consideration in cardioplegia delivery. Number one is temperature and blood crystalloid ratio. This ratio is so important. Del nido and blood cardioplegia usually administered at 4 to 8 degrees centigrade or Celsius. And for ratio, blood cardioplegia is 4 to 1 ratio, actually. Sorry, I say ratio. And del nido is 1 to 4 ratio. Custodoil or HTK, the ratio is blood crystalloid ratio is 0 to 1 because HTK just contain crystalloid and there is not blood in HTK. But don't be confused. HTK blood hybrid contain a little blood. So second one is maintenance dose adjustment. Some centers use reduced maintenance dose for short ischemia or smaller patients, and by this reduce edema and electrolyte shifts. The third one is special consideration for some patients who have LVH, hypertrophic heart or stenotic coronaries may need larger induction dose, earlier supplemental, and a retrograde delivery is better for this patient. Number 4 is institutional protocol variability. This protocol differ by surgeon, surgery type actually, and equipment, and it's better for us to always follow institution specific guideline. And the last one is redosing strategies in line cross clamp. For example, for Del Nido, we know Del Nido is single dose, and when we use Del Nido in our cardioplegia solution, actually we don't need repeat dose. But if the surgery, the time of surgery is more than 90 minutes, we actually repeat the dose of Del Nido. But some patients, such as pediatric or left ventricular hypertrophy or LVH, need to repeat the dose of Del Nido after 30 to 60 minutes. So go to next slide, please. Thank you. This table show the delivery technique of cardioplegia solution. One method is antegrade. In this method, we injected cardioplegia solution in aortic road into the coronary arteries, and we usually use this method. The pressure of this method is so important because more than the normal range, maybe the patient lead to rupture, and less than maybe lead to less circulation and oxygenation. The normal range of antegrade method is 60 to 100 mmHg or millimeter of mercury, typically 70 mmHg. Another method is retrograde. The normal range is 30 to 40 millimeter of mercury, mmHg actually. We injected cardioplegia solution via coronary sinus, following backward to the venous system into the coronary arteries. The pressure of this method is so important because the risk of rupture in veins is very actually more than artery. And the other methods, such as combined antegrade and retrograde, actually simultaneous monitoring required. And there is another method, such as ostial. We directly injected the cardioplegia solution, for example, in the left coronary arteries, or LCA or RCA, right coronary arteries. So go to next slide, please. Yes. This is a slide about the temperature of cardioplegia solution. Usually we injected solution in actually cold. The temperature is 4 to 10 degrees. And actually the advantages or purpose of this temperature is maximal metabolic suppression, and sometimes we can reduce the temperature of cardioplegia solution very much, because, for example, for some patients who have low EF, low ejection fraction, it's better to injected cardioplegia solution TPD, and the temperature of TPD is 20 to 28 degrees centigrade or Celsius. And the purpose of this temperature is balance between protection and enzyme activity, actually. And warm type, the temperature is 32 to 37 degrees centigrade for reduce vascular spasm and flush metabolism. And the last one is about hot shot. Always we injected hot shot at in 37 degrees centigrade because we wanna wash out metabolic acidic metabolites and actually reduce reperfusion injury. For TPD, sometimes blood solution injected in TPD temperature, actually. So go to next slide, please. Thank you. Okay, this slide talk about the dosing and the timing of cardioplegia solution. For Del Nido or DNC, the initial dose is around 20 milliliter per kilogram, and the maximum of induction dose in about 1,000 milliliter for patient more than 50 kilogram. But for a child, say, the initial dose is better to be 8 to 10 milliliter per kilogram. And the maintenance dose is 10 milliliter per kilogram, and actually after 60 to 90 minutes. And always don't need to repeat dose of Delnido. Another one is ST Thomas blood cardioplegia, like backbreak and high potassium blood. The initial dose is 10 to 20 milliliter per kilogram. And if I want to talk about each one of them, for example, ST Thomas, the initial dose for adult is 10 to 20 milliliter per kilogram, and for child and infant, the initial dose is 30 to 40 milliliter per kilogram. And we repeat dose of this solution, ST Thomas actually, after 20 to 30 minutes. And for blood, the initial dose for adult is 10 to 20 milliliter per kilogram, and for child is 25 to 30 milliliter per kilogram, and for infant is 30 to 40 milliliter per kilogram. And we injected after, we repeat injected after 50 to 20 minutes. And the last one is HTK. Actually, for HTK for adult is the normal. If I wanna say it, actually, it's better to say it. The dose of HTK in reference is, if I want to say it exactly, the reference is 1 milliliter per gram myocardial mass, related to myocardial mass, and it's around 1,500 to 2,000 milliliter in adult, and we injected in 6 to 8 minutes. But some perfusionists say the dose of adult 20 milliliter per kilogram, and they are same, not different. And for child, the dose of HTK is 25 to 30 milliliter per kilogram, and for infant is 30 to 40 milliliter per kilogram. And the redose of HTK is around 500 milliliter. I said volume and intervals depend on solution composition, blood ratio, and patient condition. So go to next slide, please. Thank you. Choosing solution depend on many factors. Depend on surgeon, depend on patient, depend patient condition, and the routine cardioplegia solution that the center use. For example, for pediatric, we say Delnido is better. Actually, demonstrate that Delnido is better. And for hypertrophic heart, cold blood and short interval is very good because high metabolic demand. And for heart failure, the patient who have heart failure, warm initial is good. And actually, we choose the type of cardioplegia solution by consider all of these factors and choose the correct of them. So go to next slide, please. Okay, common errors and complication. High retrograde pressure, I say you, lead to coronary sinus rupture, so it's important to control the range of pressure. Overcooling lead to coronary spasm, so control the temperature is so important. Inadequate repeat dosing lead to spontaneous heart activity during surgery. Incorrect blood to crystalloid ratio lead to electrolyte balance. So it's important to control the ratio between crystalloid and blood. Go to next slide, please. Thank you. Myocardial protection mechanism. we reduce the metabolic demand by reduce the temperature of the heart, actually cooling, and airways by adding potassium, high potassium. Maintain pH and ionic balance, especially potassium and calcium are so important. Minimize ischemia, reperfusion injury, and prevent irreversible myocardial damage. So go to next slide. Yes, this is the last slide and the summary of this session. Cardioplegia solutions are essential for myocardial protection during open heart surgery. Understanding the type, routes, pressure, dosing, and potential complications allows perfusionists and surgical team to achieve safe and effective outcome. So thank you for hearing me. And if you have any question, please leave your question in comment, and I'll be happy to answer your questions.
Okay, so guys, I hope you found this session helpful. And if you have any doubts or if you have any questions, you can comment your questions in the live chat section. So we'll pick the questions and we'll try to answer the questions. Okay, we have few questions over here.
Yes.
Okay. So the question is, can you explain about microplegia?
Microplegia,
Micro,
yes.
yeah,
Yes, I say microplegia is a type of cardioplegia solution with very concentrated
yeah,
cardioplegia drugs in a small volume of blood cardioplegia, of blood actually.
yeah. And the benefit of microplegia is that it reduces hemodilution.
Yes.
As yeah, it
For
is
child,
given in the yeah, yeah. Tell me, yeah, you can tell. You can
uh,
explain. Yeah,
yes, I think this micropelagic solution for child is very important because the risk of hemodilution
yeah,
for child is so important. So it's very beneficial for them.
yes. It reduces hemodilution, and it is given in the ratio of 20:1 or 40:2. So the crystallite solution is very less, and it is given as a blood cardioplegia mainly. So the oxygen delivery is good for the heart during microcardioplegia. Okay, we have next question. What is the optimal cardioplegia for CABG in patients with an ejection fraction of less than 30%?
Low EF, it's better to use warm cardioplegia and some cardioplegia, blood cardioplegia is very good for them because they are low EF, and we should to injected some cardioplegia that reduce the risk, and I think blood cardioplegia is very better for them.
Okay, we have one more question. So, what should be the minimum and maximum line pressure that is accepted while giving antegrade retrograde cardioplegia?
It means that what happened if we injected in high or low? Yes.
What is the minimum and maximum line pressure? So,
Oh, okay,
yeah,
okay.
yeah, whenever we give cardioplegia.
The normal ratio, I say for antegrade is 60 to 100. Average is typically 70, but some reference say 60 to 80 mmHg. But for child, it's better to injected antegrade method in, for example, is less than adult, and the normal range of retrograde is 40 to 50 mmHg.
Yeah. Okay, we have one more question.
Yes.
So, which
Which
cardioplegia?
cardioplegia
Yeah.
transplant? For example, some cardioplegia like HTK used for cardioplegia transplant. And I think there are some new solution like Perfadex. I know you're hearing this name or no, or Esteem solution. It's very good for transplant.
Okay. Okay, so we'll wait for some time.
Okay.
So guys, if you have any questions, you can comment in the live chat section. So comment your questions as soon as possible, so that because we don't have much time. So we have one more question. Can we give St. Thomas cardioplegia through Cole chamber, and how it is given?
Uh, I say the initial dose of ST Thomas for adult is about 10 to 20 milliliter per kilogram, and for child is and for child actually an infant is 30 to 40 milliliter per kilogram.
Okay. Okay, so we'll wait for some time. If there is any questions, you can ask. We are at the end of our session. I request Zahra to tell her about the next topic which we are going to discuss in the live session.
I think it's delivery system,
Okay.
delivery strategies actually. And I think it's better to have some section that talk about a new solution, a new article, a cardioplegia solution, and we update each other from new articles and new solution
Yeah.
in the board. It's very helpful for us as an perfusionist.
Okay. So guys, in the next session, we will have a discussion uh, on the topic that is delivery types of cardioplegia. So we hope you join us in the next session. And now we have one more question.
Yes,
How do we give warm hot shot? Should we add cardioplegia in it or just blood?
actually, it's depend on many factors. We injected, if I want to talk about completely, we injected hot shot in 37 degrees, and we usually injected in antegrade, and the pressure of that is 60 to 80, and we can add a lot of drugs in it. For example, usually we add magnesium, antioxidant, and mania and other drugs by consider the patient condition to reduce the risk of reperfusion injury.
Okay. So have you ever presented a patient with a stone reason? I think it is about stone heart.
So, if you ever presented a patient,
Have you experienced a patient with a stunned myocardium or stone heart?
actually, no, I don't. Stone, can you describe it more for me?
See, actually, sometimes what happens is if the patient is having low ejection fraction,
Yes,
and if after giving cardioplegia, if the heart is not arrested properly,
yes,
or our cardioplegia delivery is not adequate, or the composition of the cardioplegia is not sufficient, and if the myocardial protection is not good,
yes,
so when we release the clamp, after releasing the clamp, when we flush the coronaries, or if when we perfuse the coronaries,
yes,
the heart activity doesn't come back, because while giving cardioplegia, we didn't maintain adequate pressure, or the composition, the additives in the cardioplegia was not sufficient, or the temperature was not sufficient, or the myocardial protection due to insufficient additives, or uh, temperature management of the cardioplegia was not good. So the myocardium gets stunned, so it doesn't uh, come to its normal activity. So that is what it is called as the stent myocardium due to cardioplegia, if the myocardial protection is not good
Yes.
after
Okay.
giving cardioplegia.
So in this patient, they are high risk, and we should to do all the things that we can do to prevent to increase the risk of injury. For example, added some drug, inotrope, and other drug, for example, antioxidant
Yeah.
and magnesium to prevent uh, the injury.
So we have one more question.
Control this patient during CPP so carefully,
Yeah.
and by carefully monitoring, we can prevent this injury.
Yes, we should maintain the temperature at 4 to 8 degrees,
Yes,
and yeah, and we should make sure that the cardioplegia which uh, we are giving at a proper pressure. We should maintain the pressure,
yes,
temperature, and the composition of the cardioplegia should be adequate, because potassium is also important and the buffers is also important in cardioplegia.
yes.
Yeah, and mostly we should. I think blood cardioplegia is more beneficial than the
Because
crystalloid cardioplegia
glucose and oxygen for the
in such
metabolism.
patients. See, because if the patient is having low ejection fraction, it is better to give the blood cardioplegia because it has oxygen in it.
Yes,
Yeah, and it doesn't cause hemodilution, and also it also delivers oxygen to the myocardium, so that is good for the myocardium.
there is another.
Yeah, we have one more question. So yeah,
It is there any recent evidence comparable? Um, there are a lot of evidence that compare both of them. We know for people, patients who have heart failure, the metabolism of heart is so low. So we can't injected cold cardioplegia solution, because by injected cold cardioplegia solution, we reduce the metabolism, and maybe after the perfusion, uh, we can't start normal rhythm of the heart. So it's better to use warm cardioplegia to maintain the enzyme activity in the cell. This different of them related to the cellular for work of the cell after the reperfusion.
okay, okay. So we have one more question. Is the addition of lignocaine necessary in the maintenance dose of delnido?
Lignocaine necessary.
Lignocaine, yeah.
Delnido contains a little lidocaine. If we consider that maybe the patient phase 2 arrhythmias, yes, it's better to add lidocaine, but still, delnido contains lidocaine.
Yeah.
All
So
of them is related to the patient condition.
yeah,
There is
yeah. Basically, lignocaine is necessary in delnido,
yes.
whether it is first cardioplegia which we give, or either the maintenance dose which we give. Okay. So we have one more question. Any consideration for renal failure patients during while giving delnoid cardioplegia?
Delnido It's for what? Renal failure? Okay.
Any special considerations? Should we take any precautions for renal failure patients
No,
which are having
yes,
CKD?
Delnido is very good for them and actually help to prevent reperfusion injury after them.
Yeah.
All of these solution, each one of them have advantages and disadvantages. So we choose the best one, and there is no solution that we can say, okay, this is very good. There is no problem of this solution. So we just consider the better of them.
Yeah. Okay. So basically, Del Nido is actually a good cardioplegia, which has a better myocardial protection, and it doesn't have any side effects. Like most, we have not seen any side effects on kidney.
Actually, for renal failure, there is some solution that is better, and there is new article that demonstrate that this solution is better for renal failure, such as let me show for Calafure or SPK is better
Okay.
for renal failure. Or for example, for the people who have diabetes,
Okay.
Calafure and SPK is very better for them.
Okay. We have one more question. So, how is warm blood cardioplegia given, and what's the composition, and what's the arrest time, and any other things that we have to take care of?
For warm liquid, we just injected blood.
Okay, I think there is a network issue. Okay, so guys, I hope you uh, had a wonderful time, and thanks for all the questions in the live chat. If you have any questions or if you have any suggestions, you can directly message us on WhatsApp or DM on Instagram. For now, so as you can see, there is a technical issue or network issue. So Zahra is not with us now. She has left. There is some technical issue. We will wait for some time. Okay, so Zahra is back with us.
Uh, so
I think there was a network issue on your
yes,
side.
in our country we have network issue always.
Okay. No problem. We'll continue. We have one more question over here.
Yes,
So uh, maybe this is the last question.
yes.
Is esmolol additive of cardioplegia? Esmolol.
Smaller, yes, maybe some perfusionists can add it, but I add it until now.
So what do you like? What do you suggest about it? Is it necessary in the cardioplegia?
Um, Actually, maybe it's 50-50. I can't say it's exactly necessary or no.
So actually, it is a adrenergenic blocker,
Yes,
but it is not necessary as we are giving potassium. It is not necessary to add esmolol every time. It has its own action, but it is short acting.
yes.
Yeah. Okay. So thank you guys for joining with us, and we are about to finish our session. If you have any questions, you can still comment your questions in the live chat. We will wait for 2 minutes. Okay, so it was a wonderful session,
Thank,
and thank you, Zahra, for joining with us.
thank you, sir. Thank you.
Yeah, you have explained wonderfully. You have cleared all the doubts, and we'll see you in the next session with another topic.
Sure.
Yeah. So thank you guys for joining, and see you in the next session. Thank you, Zahra, once again, and wish you all the best.
Thank you.